I'm Professor Dr. Syed Amir Gilani, Dean of Faculty of Allied Health Sciences in University of Lahore. I will be your moderator today. There are many people who are joining. If you have friends, you can advise them to go to Facebook of Afro-Asian Institute. There is live streaming. They can ask questions there. And one of our guy will be putting all the questions in the chat in question answer of this webinar so that we can have answers from the speaker. Akif, is the Facebook on?
Yes, sir.
Okay. So, dear colleagues, friends, seniors, and students, it's my pleasure to introduce Dr. Richard Bees, who is a consultant radiologist in Queen Elizabeth Hospital, London. He is also one of the teaching staff at one of the very renowned hospital, which is King's Hospital in London, and King's College London, sorry. And he's MRCP and FRCR, which is the fellowship in radiology. He will be talking about the role of CT and other imaging techniques in COVID. So without wasting time, I will invite Dr. Richard Bees. Please share your screen and please share your knowledge with us. Dr.
Thank you.
Bees.
Thank you, Professor, for asking me to talk today. Yes, I'm a consultant radiologist, 20 years experience in the National Health Service. And obviously, we're all going through this pandemic, and I'm talking today to colleagues. This isn't necessarily about teaching, it's about sharing, it's about a conversation, it's about a conversation about this pandemic. And really, it's not, it is a modern problem, but really it's as old as time of pandemics. And as we all know, I'm based in London, in Woolwich, and we heard about the first outbreak in December. And then we saw on our television screens China building huge hospitals, 10,000 beds in January to early February. And then later we saw it arrive in Italy, and they were having a terrible time. And then we had our first case really mid-February in London, and we were the first hospital to have a case of COVID. And the peak of our pandemic really was in the middle of April, where we had at least 80 patients ventilated in the hospital. And we'd actually changed the whole of our hospital to address this COVID problem. So we'd stopped all routine work and really geared ourselves to just dealing with this, this infection. And as of, we all know it originated in Wuhan and came via the airplanes and became into 187 countries very quickly. The biology of corona, as we probably all know, it's an RNA virus, and it's got two hosts, mammals and birds, and is known to cause respiratory tract infections, which can vary from mild to lethal. That has always been known. I've got a book on immunology 20 years ago written saying that a cold virus in a child can be a deadly pneumonia in an adult or elderly person. And we've already had some outbreaks of SARS and MERS, which originated, SARS originated in China with 8,000 infections and 800 dead, and MERS in the Middle East with a 30% mortality, but a lot lower numbers, only 815 cases. And viruses have been with us for thousands of years, ever since we started living with animals. We tend to move over from animals, and certainly as we moved from hunter-gatherers into closer communities, we settled down in the Neolithic period and became farmers. We became more crowded. And it's said that 10% of the genome is made up of old viral infections from previous generations. And a non-microbial infective agent was suspected in rabies, submicroscopic in 1884, and it wasn't until 1940, with the invention of the electron microscope, did we start to see these viruses, and that's an influenza virus on the right. And pandemics, they've been with us for many years, thousands of years, and some of them have actually changed the course of history. So the Antonine Plague in 190 AD, a smallpox plague, supposedly 10 million dead, well, that changed the Roman Empire, which had been there since 700 BC. And the largest pandemic probably is the Black Death of the 14th century, with up to 2 million people dead and a third of Europe. And then the most recent one, about 100 years ago, a very large flu virus, the Spanish flu, with up to 100 million dead and an infection or death rate of 10%. And this is just an infographic on the sides of these pandemics. As you can see, the Black Death in purple here. Here is by far the largest death rate. And in fact, down here is COVID. It's really about the fourth or fifth least lethal ongoing pandemic that we have. And the most modern deadly pandemic is HIV, with up to 20 to 40 million dead. And we probably all know this and about the symptomatology, often asymptomatic in young people. Fever and a cough was our two main symptoms that we were looking out for, and then loss of smell and taste became added. And the diagnosis is on symptomatology, but radiologist does have a role in early diagnosis through the chest X-ray and ultrasound. We found the swab can be quite insensitive, up to 70% accurate, down to 50%. And then we use CT for confirmation sometimes, but generally for the complications of this virus. The timeline of the virus infection, it's generally a 5-day incubation period, 3 days cough and temperature, and about day 4 you can detect early lung involvement with CT. And the real problem is in the second week, on the 10th day, if you are going to succumb to this illness, it becomes a devastating bilateral pneumonia and respiratory distress and intubation. And if you end it on a ventilator, then it's got a very high death rate in our experience. At day 14, if you're lucky enough to recover, you get resorption of the fluid in the lungs, and you can then get post-viral problems such as fatigue and Guillain-Barré and all the other sort of post-viral complications. And the immunity, well, it is thought if you've had this virus, you will generally be immune. There are two responses, the T cell response and the B cell response. And this is a mild illness in most people, particularly in the young, and certainly in the UK, under 45, only 325 deaths. The majority of the people who die from this illness have got comorbidities such as obesity and type 2 diabetes, and generally over 60 years of age, and males are particularly susceptible. And the UK death rate at the moment is between 30 and 40,000. The radiology, the chest X-ray, can be very insensitive in the early part of this illness. It can become abnormal at about 4 days, and it's a ground glass opacification. It's often bilateral and peripheral, and the chest X-ray can be insensitive because it's difficult to appreciate ground glass, which is neither consolidative with lots of silhouette signs, and also because there's a lot of lung behind the diaphragms and behind the heart. And it's an interstitial process, and as we all know, the interstitium, hopefully we all know, is the connective tissue that holds the lungs together. It's the lymphatics and connective tissue, and you get these subpleural lines, interlobar septal thickening and lobar septal thickening in the periphery of the lung. If we remember, the outer 1 centimeter of the lung should be black, devoid of anything, and we start to see lines. And it can be quite subtle on the chest X-ray. And ground glass is a shadowing that doesn't obscure either the bronchi or the vessels, and doesn't obscure any of the silhouettes. And the progression on chest X-ray, well, it can start with a peripheral bilateral ground glass pneumonia, as we have on admission here. And then in a very rapid period of time, this is about day 10, it can progress very rapidly. And my colleagues tell me that these patients can be very sick very quickly as they develop RDS. And as we go through the series, you'll start to see that the air in the lungs, or the dark area, which is the air in the lungs, becomes obliterated with white or airspace shadowing or ground glass, and it becomes more confluent. As it becomes more confluent, it becomes more fluid, and you lose the silhouette sign. So you lost the silhouette sign of the right hemidiaphragm, the right heart border, the left heart border, and the left hemidiaphragm, and then the lungs become full of fluid. And at this point, these patients are very hypoxic, almost drowning in their own fluid. And it's not necessarily the virus that's causing it, it's the body's response to the virus. It's the immune system, it's the fluid, and that is the general cause of this worsening of this airspace shadowing. And you can get superadded infection on top of that. This ground glass is not a solid. It's not solid like an effusion or consolidation. If we have here, this is pneumonia where you've lost the heart border, the silhouette sign. This is pretty dense. You can get that later on with infection, and again, it's not rounded like a tumor. It's this ground glass, almost veil-like opacity that occurs in the lungs and progresses. And we've used ultrasound in the early diagnosis of this because the shadowing is peripheral and it affects the periphery of the lungs. Here's in the CT. We get thickening of the lobar and interlobar septa. And then we have this is the normal ultrasound findings of a lung. You get these A lines. It's a reverberation artifact where the lung is full of air. And when you get thickening of the septa and interlobar septa, you start to get these B lines, which go all the way through all the way to the bottom of the image. And we had a conference with some Italian doctors, and they recommended that we use a 3.5 megahertz probe and that we go across the ribs, and we can use it as a rule in, not a rule out, and pick up this peripheral shadowing that may not be seen on the chest X-ray for early diagnosis. And this was published through the British Medical Ultrasound Society, and is our help for the national guidelines of diagnosis. And a lot of A&E doctors are using ultrasound to pick up early COVID, particularly in the ambulance and before they actually get into hospital. And the CT is first described in 1940 in chickens, the SARS and MERS, and that's a picture of a coronavirus. And then I talked about viruses, been with us for thousands of years, and that's a picture of an influenza virus, or sorry, coronavirus. And the 1940 electron microscope allowed us to see them. And then we talked very briefly about the history of pandemics, the Antonine Plague changing the Roman Empire, the Black Death in the 14th century, causing a third of Europe to die. Took 100 years for the population to recover. And then 1918, the Spanish flu, over 100 million dead. That pandemic lasted 2 years. And the second wave was deadlier than the first wave. And then, sorry, there's an infographic about the history of pandemics showing the scale of these pandemics and how corona is quite a small death rate compared to the Black Death and the most modern death rate in HIV. Can you see this screen, Professor? Yep, and here's HIV, about 20 to 40 million. That's the most common, most deadly recent pandemic. This is the plague of Justinian, which was thought to be a smallpox plague. Smallpox used to kill before immunization in the 1800s. It was a big killer. It killed a third of people and disabled a third. So just this infographic just shows the scale of what we're dealing with and how they've been with us through history. And then we went through the symptomatology, and then talked about the chest X-ray, the swab, and the CT. And then here's the timeline of this illness: 5 days of incubation, 4 days CT involvement. You can see early COVID. And the day 10 is the intubation day. If you get RDS, this is when you're in trouble and you've got bilateral pneumonia and if you end up on a ventilator, very hypoxic, it's got a very high death rate, and hopefully recover at 14 days. And then the chest X-ray showing bilateral ground glass, how subtle it can be and how it can be hidden behind the heart and behind the hemidiaphragms. It's bilateral, it's peripheral, but it does lend itself to the use of ultrasound, using ultrasound looking for the peripheral consolidation, the B lines, which is thickened interlobar septa, and subpleural fluid. And then our friends in Italy told us how to do it using a 3.5 megahertz probe here. And this is the technique they use anteriorly in the midline and posteriorly. It's a rule in, not a rule out. And this shows you the CT, how it's so peripherally situated that the ultrasound allows ultrasound to see this. If this was more centrally situated, then it would be impossible to see this because air reflects sound waves, and it's only because it's subpleural that we're seeing it on ultrasound. And we're using it to increase our sensitivity in early COVID, and also using it on ITU to look for consolidations and pleural effusions. And then the CT is the most sensitive. There's a series from China showing it's the most sensitive to pick up this bilateral ground glass. And this is ground glass here. You can still see the lung markings. It's a veil-like opacity. It goes out to the periphery. And then you get lobar and interlobar thickening, and it's said to be crazy paving. It's got a very high positive predictive value, a very high negative predictive value for lung involvement. You can still have systemic problems despite not having pneumonia. And then did talk about this chest X-ray and the progression, how quickly it can progress from this veil-like ground glass opacification and then becomes more consolidative. And as you come down to 72 hours, you lose the silhouette signs because you've lost the air soft tissue interface. You've got bilateral airspace shadowing. You've got bilateral pneumonia. And I said, it's a response, an immune response to the virus. And this is, these patients are hypoxic and require assisted oxygen and ventilation or positive pressure ventilation. And then I just talked about how the ground glass is slightly different to the more solid pathologies we see, such as consolidation here, which is a lot more solid, and loss of the airspace, the air soft tissue interface of this is a right middle lobe consolidation. Generally, this is an interstitial process. And here we've got a mass. So you can see a silhouette of the mass. And it's just not that solid, and a pleural effusion at the bottom here. And then what we've seen is this is just not a pneumonia, it is a systemic problem. And we've seen a lot of complications. Not only have patients presented with mental health problems such as psychosis and mood disorder, and they present with confusion due to hypoxia, but they can also get a hemorrhagic stroke. We've seen that. It's got a prothrombotic ability that's, like all inflammatory processes, a prothrombotic ability. If you think of Virchow's triad, the causes of thrombosis, which are stasis, vessel wall damage, and hypercoagulability, we're seeing hypercoagulability secondary to this virus. And it also seems to have a microvascular complication. So we're seeing a lot of renal dysfunction, creatines of about 300, and that's not because of hypotension, that's because of microvascular involvement. And sometimes we have seen a couple of cases where the creatinine is increased suddenly to 800, and we've discovered renal vein thrombosis, so large vessel thrombosis. Equally, we have hypoxic patients who become suddenly more hypoxic. We think about pulmonary embolus, and we see CTPA here there's a little arrow showing a thrombus in the pulmonary artery. Other complications, well, we've seen pancreatitis, colitis, and lots of just pro-inflammatory complications. And I've been in touch with my colleagues in Southampton talking about immunology, and my Professor Chris Edwards. The imaging of this is not dissimilar to a flare-up of systemic lupus. In fact, the lung findings are very similar, and the fact it's microvascular and prothrombotic and the complications. And we've been postulating whether that lupus could be sparked by some viral infection and then be a consequence of that. I've also talked to immunologists about why people over 45 are susceptible. People talk about T-cell response becoming more sluggish, and as we age, the thymus becomes atrophied, and you need T suppressor cells to keep the immune system in order. And again, from a lupus update, they're concerned whether suppressor cells are not working properly, and that allows the immune system to go into overdrive and cause all these complications. And any of these complications worsen the prognosis. So if you have renal impairment or hepatic impairment on the background of pneumonia, then the outcome is worse. So hopefully I've covered most of the imaging from the early diagnosis to the chest x-ray, CT findings, the use of ultrasound, and the use of the complications that we're seeing. And this is just our experience. We're all fed up of this virus, and we're quite in Britain, we've all got post-viral fatigue. We're sick of talking about it, but it has left a footprint, and the footprint is in radiology. And we're in a period where we actually have no patients in the hospital with this illness at the moment. Our peak was in April, as I've said, but now is a time to look at what is left behind and try and learn, because our winter will be coming in November, and we're concerned there'll be a second peak. And just another point, at the moment we have quite a high infection rate in the UK, but it doesn't seem that we've got a high mortality rate. So has the virus changed? Is it a different demographic of people getting this virus? Is it because the weather is better and our immune systems are better? All these questions at the moment are ongoing, but it's quite clear that it is highly infectious with an R of 3 droplet spread with more than one host, and there's a good chance that it will continue to spread. It's just about, if we can just change this virus into a non-mortal virus, i.e. the death rate disappears, then it will just become a cold, as it is in many people under the age of 45. And just for another brief point is that from Sweden, we've heard from the doctors, they say their pandemic is over. They didn't lock down, they didn't close their schools, they carried on as normal. They have a population of 10 million, they've had 7,000 deaths, and they're seeing no cases of COVID at the moment, and they estimate that their herd immunity, or their immunity, is about 50%, i.e. 50% of people have had it, and therefore there is, the virus has less ability to spread, but we'll have to keep an eye on that. They had a totally different approach to us. We locked down, and they didn't lock down at all. And so that comes, I'm sorry about the technical problems, sorry about not seeing my screen, really apologize for that. So if there are any questions or we can have a discussion, that would be good. Are you there, Professor?
Thank you very much. We are open for questions, and people are writing questions. Dear attendees, kindly write your question and answer slate. I have got a question there from Aisha Khalid. She is saying that any effect of home moisture and temperature on coronavirus as it does on influenza virus in literature. So she's asking, is there any effect of moisture or temperature or mobile phone on?
Is there an effect of temperature and moisture on the virus? Is that the question? Yeah. Well, Well, certainly in
Yes.
winter we had this virus, and as the weather improved in our country, it seemed to become less potent. And we've had some outbreaks in meatpacking factories where the temperature is low. And if you think about it, our immunity seems to change from winter to summer. When I did acute medicine, our acute medical unit was empty in summer and full in winter. For whatever reason, either the light or the temperature seems to affect our immunity. And of course, every year we have a recurrence of influenza. It seems that we are more susceptible in winter. And I think I've said already that, at the moment we've got high infection rates, but our death rates are really low. So yes, I think environment has got an impact on this, and it may be that this recurs every winter.
The next question is from Dr. Khalid Ghaznavi. He's saying that in routine life, what do you think, what are the measures which were taken in UK to save especially the vital organs of human being from COVID?
The vital
So
organs
asking, yeah,
on ITU? If you look at the difference between the pandemic in 1918 and today, the only real difference is oxygen. But as we've learnt more about this virus on ITU and the prothrombotic problems, then we have been using anticoagulation, particularly in the second week, to try and prevent this coagulopathy and protect the renal function and hepatic function. We've also done a big trial, a recovery trial, and it's reported that using dexamethasone has an ability to dampen down the immune response and reduce the death rate by 30%. So those are the main two. It's mainly supportive, to be honest. And there are lots of people who don't get to hospital with this virus. They actually, I know of 2 nursing homes where obviously the residents are elderly, 70 to 80 years old, and COVID arrived and half of them died, and they die in their beds. You don't necessarily have to die of the pneumonia. It can cause all sorts of other complications, such as myocardial ischemia, myocarditis, and arrhythmias. It can be just quite deadly, particularly in that age group. I hope that answers some of the questions.
Yeah, there is another question, Doc.
Yeah.
Sumayya Atiq, she's asking, is there any effective medicine or vaccine yet tried on human being against COVID?
Well, we've had a big trial in Oxford. I think they're coming up with a vaccine. The vaccine over many years has proven very difficult. I think it's the S protein, one of the arms of the corona they're targeting. But ever since SARS, they've been trying to generate a coronavirus vaccine, and they haven't been successful. But we have had big trials in Oxford, and there is some hope that that they may bear fruit, and we would get a vaccine. What was the other question? Sorry, Professor.
Yeah, the next question is from Mariam Maqsood. She's asking that as there is a lot of radiation in X-rays, CTs, and other tests which are done by radiologists.
Yes.
Even if the patient of COVID is survived, she's asking that is there the risk of cancer will be raised in that patient who survived from COVID but had a lot of CTs done?
Yes, that's a good point. Well, the chest X-ray is a low dose of radiation, as you know, Professor. Ultrasound has no radiation. And certainly in our hospital, we've got one of the new generation CT scanners, which is 1/5 of the normal dose. So we're down. So, on our old scanner, we would do a CTPA. I can do 5 CTPAs, the same radiation dose as the old scanner. And the HRCT is a very low dose of radiation. I personally wouldn't be worried about radiation problems, because if you are in that situation where you're having multiple imaging, it means you are pretty unwell and have complications. And I'd be more worried about the virus than I would about radiation. It's all about risk and benefits. We assess before we image everybody the risk and benefit. Will they benefit from the imaging? And everything has to be discussed with a radiologist, particularly a high radiation imaging such as CT. And we always try and do it at the lowest possible radiation dose and the lowest possible exposure. But we haven't got lots of patients having many CTs. They'll have 1 or 2 or 3. But this, in the high risk group, this is a deadly pneumonia. So I personally wouldn't be worried about radiation dose.
The next question, Prof. What is the main difference between COVID patient lung X-ray and pneumonia patient lung X-ray? Is there any difference, or it looks like pneumonia? If we find pneumonic patches, how can we differentiate either it is COVID patient or it is just the other type of pneumonia?
Well, that's right. I think I tried to reiterate this is a ground glass veil opacity that's bilateral and peripheral. And you can get it, it's pretty non-specific. You often get it in atypical infections and other viral infections such as CMV. So that can be a diagnostic problem. But it is so peripheral and is so bilateral that in this environment we assume it's COVID until proven otherwise. And if you can see very clearly the silhouette signs, and here we've got some ground glass. It's just this veil here, and you can still see the lung markings and the bronchi, which is the ground glass. And if we go on to a really good pneumonia, which is what I tried to show here, the lung becomes solid and white and dense, and you lose the air soft tissue interface. And if this patient came through in the COVID time, we would say this is a right middle lobe pneumonia, probably of bacterial origin, and we wouldn't be talking about COVID. Equally, if we see patients like this with a silhouette sign here of a mass, this isn't like COVID, this is a soft tissue mass. We'd be thinking about a lung primary. And equally, look how dense this is, where you've lost a silhouette sign of the hemidiaphragm here and the right heart board. You've got a new silhouette sign, air soft tissue interface, and this is a pleural effusion. We can differentiate other chest pathologies from the ground glass that we see here of this viral infection. Does that make any sense?
Yeah. The next question is, Doc, from Suleiman Shamit. He's asking that, what do you think, how long COVID is going to be there? Is it coming next year again with different signs, symptoms, especially on radiological finding? Do you think there will be other appearance, or we can predict any other thing?
Well, I'll tell you, we are worried in the UK there will be a second wave, particularly in winter, and it may occur with influenza. So so viruses in the past, I'm sure you all know this, viruses in the past tend to disappear. There's several reasons they disappear. Either they mutate into a less aggressive form of the virus and don't kill the host, or enough people become infected, up to 50 to 60%, so the transmission rate R goes right down. And that's what happened in the influenza virus of 1918. It's called herd immunity. But we haven't got herd immunity in the UK. We've got a very low infection rate, probably 5%. So there's still lots of people who are naive to this. So we are worried about this continue, and it may become something we have to live with and it keeps recurring in winter. In 1500, there was a virus called the sweating sickness virus in the UK. There were 5 waves. It lasted 70 years. It killed the future King of England, which was Arthur Tudor. And because Arthur died, then Henry VIII became, so it actually changed the course of our history, and Henry VIII became king. That was in 1500. So yes, this could continue. However, if we do get a vaccine, then that is a way out, because then we would get herd immunity, and hopefully this would be a thing of the past, or certainly less of a problem.
Doctor, we have another question, that if we have a patient of severe COVID infection. And what we will prefer, we will go for HRCT, or we can also have his CT brain to rule out the suspicion of hemorrhage.
I think, well, in our diagnostic pathway, we don't use CT and unless we're uncertain of the diagnosis or there are complications. So our diagnostic pathway really is chest X-ray, and clinical is so important in this. It's about hypoxia, and that's what decides what happens to the patient, whether they're admitted or they go to ITU. And you would only consider doing other CTs, such as a brain CT, if the patient was symptomatic. You wouldn't do it as a screening at all. So CT really is reserved for difficult diagnoses and complications of this in our practice. And we realise that practices vary around the world. I think in parts of China, they're using CT to diagnose patients. CT obviously is a radiation dose, but it's also, we have to clean the room afterwards, and that takes a long time, and it's a lot easier to do chest X-rays and clean the units.
We have another question, Doctor.
Yes.
Somebody is asking that is it possible to linger on the difference between the duration between two CTs? If patient is improving and we had a CT evidence, then how long it will take to have another CT? What will be the interval between two CTs?
Well, we wouldn't routinely do a CT to follow patients up. We generally, certainly in the UK, we don't use it as a screening test. We use it as a problem solving, or if they're symptomatic. So they say that there's clearing of the pneumonia by about 14 days. And we do post chest X-ray follow-ups. We don't do CTs. And we're doing that, one, to check that the pneumonia is resolving. And unfortunately, just like SARS, there is a fibrotic complication of this, where the pneumonia can leave you with some scarring. And again, we can see the interstitial scarring on the follow-up chest X-ray. So we wouldn't routinely re-CT patients. We really reserve CT for the difficult diagnosis or the complications. It's not really part of our routine imaging, but it is absolutely exquisite for the pneumonia. It picks up the very early ground glass better than any other imaging modality we have.
Yeah, then we have another question. Somebody is asking that, do you have any idea what was the percentage of COVID patients having involvement of CNS in addition to chest?
No, that's a very good question. I don't know how many present with CNS problems, but we have seen, when we've seen neurological complications, I mentioned already hemorrhagic stroke, dural vein thrombosis, encephalitis, we've seen temporal lobe encephalitis. So we've seen actual imaging evidence of neurological symptomatology. And also we've seen psychiatric problems. I've seen it in colleagues, anxiety and depression post-COVID. We've seen patients present with psychosis. And this isn't just particular to COVID. As we all know, you probably all know that, urinary tract infection can cause confusion and psychosis in the elderly. Any infection, any inflammation. And we were doing some work, and even we have people who are allergic to pollen. It's called hay fever, which is an inflammatory process, which people think is extremely mild. But people can present with depression and can present with mood disorders and psychosis. So it seems that any sort of inflammatory process can trigger these reactions, including psychiatric. And they generally get better when the inflammation gets better. So yes.
Yeah, the next question is that there had been an immense debate on similarity between tuberculosis and corona symptoms recently. And they said that the people who had vaccination or BCG, they had better defense mechanism against corona. Do you have an idea, is there any correlation between BCG and COVID immunity?
I don't know. I have heard that, but I haven't got any data or evidence for that. I've heard other. Um, there are some doctors saying that people who smoke are more immune to this COVID infection, and I think in time we'll start to see which groups of people are really infected. Other people have said that blood group has got a role to play. Unfortunately, I don't have any data on that. And again, it should be said that, you know, in the immunocompetent, the young under 45s, this generally is a cold. And it's the over 45s, the elderly with comorbidities, particularly obesity, particularly type 2 diabetes, that succumb to this, this illness and the pneumonia and the complications.
And the last question is that, is there any effect of CT on pregnant ladies suffering with COVID-19? She's asking that if a patient is pregnant and is positive with COVID, are we going to have CT, or we will just do the X-ray, and what will be the hazards if we do CT?
Absolutely. And pregnancy we take very seriously, but generally they would have ultrasound and chest X-ray. It wouldn't be unless they had a really a complication that they would have a CT, such as a pulmonary embolus or suspected pulmonary embolus, or some neurological problem that required a CT of the head. So they would almost certainly have a chest X-ray and ultrasound. And then in the pregnant women, we have a routine, and certainly in the NHS in the UK, that the patient has to be seen by a senior physician, such as the chest physician, and often the obstetrician, and discussed with a consultant radiologist before we undertake any high dose radiation examination in a pregnant woman. The patient has to benefit from the outcome of the test. And as I said, we're lucky in Woolwich we have a new generation CT which is of low radiation to the pregnant woman. In fact, we're investigating all possible pulmonary emboli in pregnant women with CTPA rather than VQ scan, because of availability and because actually the radiation doses are comparable. And obviously, pulmonary embolus is a life-threatening illness. We don't want to miss one, but we take it pretty seriously, and we would select the patient very carefully.
Thank you very much. At the end, I would like to thank Dr. Richard Bees for this nice presentation and very nicely addressed questions. We have another tradition of having 5 minutes to have chat between all the participants. So I will request Mr. Akif to show all the participants, so that if they want to share their pictures, they can share with the panel, they can chat with each other, they can chat with the speaker just for 5 minutes before we log off.
Sure, sir.
So all the participants, if they want, they can show their face, we can have their picture. This lecture will be uploaded at YouTube, and we are happy that they were about 19 had a subscription of 100 people who can join, but we had about more than 400 people who wanted to participate, and I was happy to see how 250 plus people were on Facebook. They were writing questions, and we were sharing here in the question answer session. So those who want to share their face, their videos, and if they have any question, they can ask us, they can ask to the speaker for 5 minutes.
Yes, Gulshan, you have raised hand. I have unmuted you. You can ask the question. Yeah, Gulshan, can you hear me? Shantu Malik, can you hear me?
Akif, can we see the picture of everybody
No,
here,
sir.
but or it is not
They
possible?
can ask questions, but we can't see their face.
Okay.
Hello, sir. I am here, sir.
Yes, please. Shantonu Malik.
Yes, sir. Assalamualaikum, sir.
Walaikum salam. From where you are?
I'm from Bangladesh, sir.
Yes, sir. If you have any question.
Yes, sir. I have one question. That is, I have just studied from John Hopkinson's University about contact tracing on COVID. There, I have found that is they are mentioning there is 15 minutes staying with COVID positive patient. That can be a contamination cause. So is it that is familiar with any other countries, that is they are also thinking like that, that is more than 50 minutes contact with positive case, that maybe causes the contamination.
Yes, Dr. Richard Bees, he is saying that is it possible if we have 60 minutes contact
No,
with the
sir,
COVID
15
positive
minutes,
patient?
Sir,
15.
15
Yes,
minutes, yes. More than
15 minutes contact, that can be dangerous. I have not seen any study, but if it is less than 15, you will be safe in that case.
Yes, I mean we've had the message. It's 15 minutes, but basically, if somebody coughs or sneezes on you, it's droplet spread. I think it's extremely infectious as this virus. I don't think you really need long contact with somebody who's infected. It's not. I don't think it's necessarily the time, but obviously, the longer you are with that person, then the more likely, if it's an infected person, the more likely you are to get infected. Particularly if you're not socially distanced. Particularly if we're inside, we've got a social distance of 2 meters at the moment. We wear face masks. We're a lot more confident outside. But I think, it's droplet spread, and you just have to inhale the droplets. I don't think it's necessarily about time.
Yes, Akif. Anybody else?
Assalamualaikum.
Walaikum salam.
Sir, I have a question. I observe one of the patient, one of my relative. He have no any symptoms like fever and other symptoms of the COVID, but suddenly he shows the symptoms of the shortness of breath. Multiple COVID tests are done, but both of them are negative. Then we go for the chest X-rays, but on the chest X-rays there are a lot of disturbance in the chest, and the patient conditions are going to worse in only 1 day, and after that the patient is expired. Then there is no have any symptoms, and also have a negative test on a COVID test, only have symptoms on the chest X. Then I suggest that the chest X-ray and CT is much better than the we done with COVID test.
His question is that it is better to have CT or X-ray other than going for the blood tests.
Well, I mean, we use a swab, a nasopharyngeal swab, and it can be negative, and we're seeing several swabs come back as negative, and then we do a CT and they have COVID. And we're seeing lots of patients who are asymptomatic, but very hypoxic, and they can talk and they have saturations as low as 80%. It can be a very difficult diagnosis to make, particularly when you've got a negative swab test and no symptoms, but these people can still be quite ill. And you don't even have to have the pneumonia to be ill. I said before, you can have myocardial involvement and arrhythmias, but we are seeing that, and sometimes people are totally asymptomatic, and the chest X-ray looks appalling. We call it, I think it's called the whispering well. They can speak and do virtually everything, but they're very, very hypoxic and they have pneumonia.
Yeah, with this we have finished this webinar. We are thankful to Dr. Richard Bees, who responded nicely to our invitation. He shared his knowledge. We hope we will be able to hear from him in near future on different other topics in radiology. We appreciate his cooperation, that he shared knowledge and he gave us some time. Thanks to all those who registered, and thank you very much to the attendees who participated very actively. With this, I will thank my team also who are working on it. And we have live streaming, then we will have it on YouTube. And all these webinars are free. There is no financial interest. It is just to share knowledge with the people. And we were happy that there were a few people from Bangladesh, Sri Lanka, Sudan, Somalia, Egypt, UAE. We will be sharing the list with the speaker so that he'll be happy to have so many participants who were interested in his talk. Thank you very much. Have a nice evening. Bye-bye.
Thank you, Professor.
Thank you, sir.